Repair of meningocele, less than 5 cm diameter. Larger than 5 cm diameter. The patient is face down, and the physician makes a midline incision and retraction through the skin, muscles, and paravertebral ligaments. The dura is incised to avoid herniated neural tissue. The physician places the neural tissue in the spinal canal. In the lumbar region, filum terminale are often identified tethering the cord and divided. The dural defect, subcutaneous tissues, and skin are closed with layered sutures. Repair of myelomeningocele, less than 5 cm diameter. Larger than 5 cm diameter. The physician places the patient prone and incises the defect to the subarachnoid space. Using a microscope, the edges of the neural placode are trimmed of skin, dural remnants, and fat. The lateral edges of the placode are sutured together to form a tube. The dura is incised and closed. Skin is closed with sutures. Repair of dural/cerebrospinal fluid leak, not requiring laminectomy. Repair of dural/cerebrospinal fluid leak or pseudomeningocele, with laminectomy. The patient is face down, and the physician makes a midline incision, retracting the skin, muscles, and paravertebral ligaments. The physician removes and prepares a graft of subcutaneous fat, freeze-dried dura, fascia, or muscle. Suction is used to keep the incision free of cerebrospinal fluid. Single dural stitches are used to achieve closure. A second needle is attached to the free suture ends and the needles are passed through the graft, which is tied down over the outside of the repaired tear to achieve watertight closure. If the dural defect is small and difficult to access, the graft can be placed inside the dura. After verifying that the repair is watertight, the physician proceeds with closure. Repair of brow ptosis, superciliary, midforehead, or coronal approach. Ptosis refers to a droop or displacement resulting from paralysis. The physician makes an incision directly above the brow, superciliary, through the midforehead or near the hairline, coronal. A dissection is carried down to the area of the brow. The skin is pulled superiorly and the brow approximated to its proper position above the supraorbital rim. The incision is repaired with sutures. Is it appropriate to report code 67900, repair of brow ptosis, superciliary, midforehead, or coronal approach, for an endoscopic repair of brow ptosis? The appropriate code to report is 67999, unlisted procedure, eyelids, as there is not currently a specific code to describe this procedure.